Tired of the conflicting advice in the world of health and wellness? Ready for clear, science-backed strategies to live a longer, healthier life? Welcome to the Duration Wellness Show. We focus on health and wellness education to help you become a better, more informed you. Wherever you are on your journey, we're here with you for the duration.
So welcome to the Duration Wellness Show. I am Dr. Anna Maria, board certified internal medicine physician with Masters in Public Health and a love of preventative medicine. And we are back for another episode, which I'm so excited about. So today's guest is Dr. Eric Edgerton. So board certified emergency medicine physician, and he spends his work days caring for patients in high stakes emergency situations. So excited to have you here. And I know that's a very brief intro, but if you want to give a little intro on yourself, you can go ahead.
Well, thanks for having me. It's exciting to be here in this context. You and I obviously go way back in our training days. So it's cool to talk at you from this end of the computer. Emergency medicine, board certified since, when was that? 2021, I think. Was I finally
Might
completed
even
that
before then. I guess.
Well, so right? Our
got out earlier, but
our residency, but then because of our oral boards, ours all of my colleagues were delayed also because of COVID. So COVID testing, we used to do an in-person thing that got switched around and delayed. So we're all like a year off. So it's always weird to think about those dates, but.
Yeah,
graduated residency 2019, and then you complete the board certification process after that.
Yeah, a lot of people probably don't know how intense it is and that you guys have to take oral boards and all that craziness.
Yeah, that was quite interesting. These days, I don't even know if they went back to in person. I think it's all Zoom now. And the format is quite intimidating. You are in a weird virtual waiting room and someone's face pops up that you have never met, never will see again. And they're some board certified emergency medicine doctor that's administering this case. And they're like, this is blah, 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 24-year-old coming in for this, that, and the other. And your time begins now. And then you have to do this crazy virtual thing. And there's a structure to it. So it's a very interesting process, effective. And a lot of medicine is physical, but there's a whole mental component to, probably 90% of the job is like cerebral. Like you have to see things, recognize, do, and then by the end of the visit or sometimes right at the beginning, then you get the physical aspect taken care of, but we have medicines and things, but that's medicine in general. It's your job. It's what do you think of this? What do we see? What do we do?
Yeah, so. No, there's a lot of nuance to it that I think people don't realize, and a lot of training to get to this point.
A lot of training.
So for you in the emergency room, what for like the average person do you think people don't really understand in terms of the ER? What exactly does an ER do that other medical settings don't do?
That's a good place to start, I guess. The emergency department and ER, emergency room, right? It used to be emergency room. There was a room in the hospital that was kind of near admissions because emergency medicine is actually a relatively new specialty in the medical history, since Hippocrates way back in the day. It started as a room off of the registration of the front of the hospital that they were like, hey, this person's very sick. We don't really have a bed ready for them upstairs. We're going to get them up there initially, but we need to do something, stabilize, they're bleeding from something and we need to stop that bleeding. So a way to figure out an acute illness and where it needs to be. So I describe my job to my patients, friends, whoever is asking as my job is the first 15 minutes of everybody else's job. The ER is rarely a place where things get definitively taken care of, but it is kind of a sorting hat for the younger crew listening to this, in the Harry Potter world.
Yeah, I like that analogy.
Yeah, it's kind of, who needs surgery, who doesn't need surgery, who needs to stay in the hospital, who doesn't need to stay in the hospital, and can we identify something rapidly that needs a different course of therapy? Maybe someone's already been on some kind of, medicine or treatment that is having an adverse reaction or event associated with that, or they're maybe thinking, hey, it doesn't seem like it's working and this thing has progressed, or it's like maybe not working and maybe we don't have the answer for that specifically. So our role is kind of to help people figure out where they are in a given course of an illness or issue, and escalate, reassure, or say, hey, looks like you're actually done with this thing. We can take those stitches out. It's rare that we remove too many other things, but that I think is probably it's a sorting, shipping facility, as it were.
No, I think that's a good explanation. Yeah.
Yeah.
What would you say are like the most common reasons that people come into the ER?
Pain or something associated with pain. And that's, from head to toe. So you have chest pain. That's a very common reason. Chest pain, back pain, abdominal pain, are very common. Sometimes people come in for emotional duress or events. Sometimes it's something that has happened literally on the road in front of the hospital and they come in by ambulance, or it happens that they've had this pain for 20 years and today's the day that they're just sick of it, is what we hear commonly, and that brings them into the ER too. So a lot of times it's pain, difficulty breathing, difficulty producing urine or stooling. Some people say, I'm pooped in 10 days and I'm here to figure that out. And that can be for a number of causes. So we get our thinking hats out and try to figure that out with them at the time. And but yeah, probably pain is the biggest single reason, and blank pain, whatever it is, and it hurts, and that's what brings me here today.
Yeah, because that can be a signal for other things. So that makes sense.
Yep.
What do you wish the average person understood better about like emergency medicine?
If someone understood this better, that objective emergencies and perceived emergencies are different things. So
I like that. Yeah.
Sometimes someone will say this is an emergency, and pain is also a relative thing, right? If the first time a child stubs their toe, right, and they've never had anything else happen to them before, that's the worst pain they've ever felt. Okay, that's respectable, and that's the worst pain they've ever felt. But a common question that I will ask sometimes, and I'm not trying to be facetious, but to try to help gauge very quickly a situation, is someone will say, oh, it's a 11 out of 12 or 11 out of 10 pain in my arm or my belly or whatever. And they'll look fairly comfortable, tolerating it well. Their vital signs look good. They'll say, this is the worst pain I've ever felt. And I'll say, okay, so this couldn't be any more severe. Like, if you stubbed your toe, you wouldn't be in any more pain. If we added a chainsaw to this situation, we wouldn't make this that much worse. And I'm not trying to be ugly in that sense, but I have to understand where they're at. And if it doesn't look like where they're describing to where they are, and there's different pain tolerances and those things. So we're just meeting these patients within 15 minutes and trying to figure out top to bottom where in this life and journey they're at, and if they've just fallen off a building or did just stub their toe. And those are different things. Now, they can be relatively more severe and perceived as more severe, but at the end of the day, I need to know, do I need to call a surgeon about you, or do I need to call internal medicine, or do I need to put a splint on this and have you follow up with someone, or do you need none of those things and just some reassurance of hey, splinters hurt sometimes, and that's okay. And, this is a little bit of redness, but this does not represent big infection. So I think that's a roundabout way of answering, what I would like someone to understand about the ER is that we are trying to address appropriately what someone comes to us with, right? Like,
Yeah.
we don't want to push the big red button and activate all these things because that takes resources and things away. So we're trying to appropriately treat and assess things at the appropriate time and the level of intensity that is required. And that's quite a challenge sometimes.
Yeah,
So.
no, it can be. But I think that that's a good explanation. And also just like going back to like emergency medicine, right? You're dealing with actual emergencies. So like when you're seeing a patient, you're trying to establish, hey, is this a true life or death emergency? You're describing this pain. Is this life or death? Or is it, hey, this is pretty severe. It is affecting you. It's not diminishing how you're feeling, but like it's not in that life or death category, right? So
Yeah.
I think that also is like something for people to remember when you're asking these questions, right?
Mm-hmm. Well, and there's different contexts of emergency departments as well. So, which is another thing that not too many people realize. Some people, and including myself, before even going to medical school, but then also before residency, you drive by a hospital on the road, and it might be the hospital down the street from your house in your neighborhood that's been there for 30, 40 years, right? Or for, I was born at this hospital. Their resources, their team of doctors is going to be fairly different than the team of doctors at a tertiary trauma center, tertiary care level 1 trauma center, or a big burn center. To the point that one of my best friends who is in a big electrocution burn incident, there's a big burn center in Orlando, but he had to fly to Texas because that was the premier burn center in the country for some of his surgeries and procedures. And so medicine is also kind of a geographical thing. So sometimes, someone will come in and kind of be frustrated that we have to transfer to another hospital at one of these smaller places that I work. And we don't have the surgeon or the technology or sometimes just the medication because of the training that is required to administer that drug from the certain staff, or the way that we need to monitor it for like neuro ICU cases, those kind of things.
Yeah.
So that's another thing as well. I think going back to the understanding pieces, like the medical system in all of its, there's a lot of critique, and some of it is very warranted, and some of it's, in my opinion, misplaced a little bit. The medical system is a system. It's not like a cut and paste, like boom, 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 here's hospital, this can do this, this can do this, this can do this. It's kind of regionally set up so that we can handle some of these simpler things in the smaller areas, and then get someone to a higher level of care in another, with efficacy to a pretty solid degree, I would think.
Yeah, no, and I think that kind of brings us into the next part, because I think a lot of people don't understand all of these nuances. And especially when people are in like a semi-emergent to like an emergent scenario, I think a lot of people don't fully understand, hey, when should I go to an urgent care? Or when should I go to an emergency room? Or, hey, is this ER down the road? Is this the ER I should go to? It's a freestanding ER versus an ER that's attached to a hospital versus their primary care. So I think that's, because I've even told people like, they're asking me medical questions and I'm like, hey, you need to go to the ER. And then I get a message, 2 hours later, oh, we're at the urgent care and they're sending us to the ER. And I'm like, well, that's why I said the ER first, right? But a lot of people, they just kind of think they're all the same. So how do you think people should think about like an ER versus like an urgent care, in comparison to like their primary care?
So one of the ways to kind of consider it, and this is one of the things I talk to my patients about, and I'll use blood pressure analogy that I give to people, because there'll be a lot of people who come in for blood pressure. And again, this is not medical advice. Please not focus on any numbers, but someone may come to the ER and say, I took my blood pressure at home and it was X, and mine's always this. So something was different, and so I came straight here. And I'll say, okay, like what was what were you feeling at the time? It's like, well, I did this thing and then I noticed my blood pressure was high. I said, okay, well, how do you feel right now? Do you have any chest pain? Do you have any shortness of breath? Are you having trouble moving your hands or feet? Do you have excruciating pain somewhere? And they'll say, well, no, I actually feel pretty good. Like, I don't have a headache. I don't have vision changes. I'm not having trouble speaking. I don't have a chest pain, abdominal pain. My urine and stool have been just fine. Those are all just fine. I was just worried about the number. And so that's when I'll say, like, well, we have treatment thresholds for different things, right? And if you are feeling bad, if you are feeling ill, feeling sick, there's a spectrum of that. You can feel like, oh my goodness, I'm about to fall over and like this has got to be the end. Like, if that's your feeling, like, it doesn't matter if your blood pressure is textbook 120/80. You need to go to the ER, because if you feel like you're about to die, like, please, for everything that is good and lovely, like, please come to us. We can that's my deal. That's my job. Like, and I'm more than happy to get that figured out with you, because that's what I train for, right? Like, those are the moments in time that we're like, boom, we've done the thing. And that's so, because sometimes I've had even family friends say, like, oh, I went to the ER and they thought I was crazy because I was like describing this chest pain, but they just kind of looked at me like I was nuts. And I was like, well, I mean, if you look and feel fine and say that you're feeling fine, but you had this little twinge, like, I don't think they're trying to say that nothing's wrong with you, but they're just trying to, again, go back to finding where you're at and what's going on. So ER, sorry, I'm typically a long-winded individual. If you haven't, I mean, I know you know this, but so ER versus urgent care versus a freestanding ER. Urgent care and a freestanding ER are fairly similar, but urgent care would be, I've got a runny nose, I need a strep swab or a COVID test, or I don't want to go to this family event with, knowing that I have this thing and spread it to someone, which, that probably, if you're feeling poorly and you think it's a virus or something possibly contagious, probably just, skip the event. But everybody has different thresholds and how they like to deal with that. And so I won't make any assertions in that regard. But it's, if you are feeling bad, if you are concerned about an imminent life-threatening thing, absolutely ER. And the biggest ER that you can find, okay, right? Like, if there's a freestanding ER and 5 minutes more down the road, you have something else going on. With ambulances, they will tell you, or if you call an ambulance, they will take you to the closest ER. They will not take you to urgent care. No. They will take you to an emergency department. So urgent care is, you're walking, you're talking, you need stitches out, you need stitches in, right? You cut yourself or something of that sort. Sometimes urgent cares can set bones. I think they send a lot of their stuff to us too. So not all urgent cares are exactly the same. So it's a tough question to answer, because this is one of those geographical answers.
Yeah, it's true. I mean, they're not all the same. They're
not all the same, right? Like, because if you're down the street from UF Jax, which is a level 1 trauma center, like, boom, bam. Like, I know personally some people that have been in bad accidents right outside of that hospital and just happened to be like, that was the closest level 1 trauma center, and they showed up and they got fixed, and they're, telling the story to this day, and it's awesome. And, and people will come to our small ones and we'll send them to bigger hospitals too. So I don't know, that's kind of a tough one, but you're walking, you're talking, you're breathing okay, and it's just like kind of a question, as opposed to, oh my gosh, you're holding your side and saying something's not right in here. If that's your situation, if you're saying this is hurting, I can't breathe right, something's not moving that's supposed to be moving, something's moving that's not supposed to be moving, go to the ER. We'll get you figured out.
Yeah, because I think people a lot of times think that they're almost the same, and that's where it's like, I think sometimes people can get into trouble, because I feel like I admit people all the time, they're like, I started out at the urgent care, and then the urgent care sent me to the ER, and then, and now they're getting admitted. Like, that's how sick they were, is that they needed to be admitted to the hospital. And so, I always tell people, it's like, urgent care is really just for, like, more easy peasy things. And again, they're not all the same, but like a lot of them will only have x-rays. Every once in a while they'll have like a CAT scan or an ultrasound, but like, you know, your imaging in terms of like, if you're having the worst abdominal pain of your life, right? Well, you probably are going to want to, you know, have a picture of that, right? So like if you're going to a place that doesn't have the ability to do that, you know, and then you also have to think about like interventions, right? So like if something needs to be done, you know, like again, in urgent care, you can't, you know, that's not where you end up getting admitted to the hospital. Or, you know, even for you guys, sometimes a specialist you'll call in and they'll see him in the ER and then they'll go home from the ER, right? That doesn't happen at an urgent care. So I think that's like helpful. And then the whole freestanding ER, I know we just talked about it, versus an attached like emergency department. I think people do not understand the difference there. Like, you know, that if you end up being admitted, well, then you're going to have to get transported to an ambulance, to another hospital, right? You don't have, and you can go into that a little bit more, but like, what has your experience been in terms of like a freestanding emergency department versus, you know, one that's attached to the hospital?
So, well, that also, so many good questions. I mean, we could probably talk for hours just on this alone, but I think this is where some people may be critical of the medical system, but I think this is probably a good example of how effective the medical system is, because we can concentrate some of these bigger, rarer, more invasive therapies and procedures and things into a place where, like you're having this issue and now we have a heart surgeon and a kidney surgeon and, general surgeon, and you have all these specialists kind of under one roof, that if something is going on, as opposed to trying to, put one heart surgeon way out in kind of somewheresville, that maybe they're not doing the cases and they don't get to, keep up with their practice numbers and volume, and not for the surgeon's benefit, but for like, if you're getting a procedure done, do you want the guy that's done 10 of them or 10,000 of them? Like most people would want the one and that happens at these bigger hospitals. And so I think more than ER versus urgent care versus freestanding, it would maybe depend also on time of day when you choose this, right? If it's business hours on a Tuesday, this would be a huge moment for you to, be involved with the primary care physician. And so it's a pretty common, I don't know, maybe a 30-60 split, just anecdotally. I don't know the actual number. Maybe I should need to know that number, of people who have a primary care doctor and they say, oh yeah, it's Dr. McCarthy. Like I see her, every year. I see her 3 times a year for this condition. And and like you said, well, I told them I think they're going to need to stay in the hospital. They need to go straight to the ER and we can get this handled. It is a part of the system that you would have a primary care doctor to help you figure that out, right? And you in the primary care setting, or like not necessarily because you do hospital stuff more than that. But from a clinic, like I think maybe we've done maybe not as great of a job as we should as a healthcare system to champion our primary care doctors, because the person sitting next to me in med school was primary care. The person training next to me in the ER on a few of our rotations ended up going to primary care. And that is a phenomenal place to start. A lot of primary care doctors can put in stitches. They can certainly take them out. They can organize care. They can help you say like, hey, you actually don't need to go here or go here. You just need to go here, and can cut out a lot of the decision making and things. And, there'd be a fee associated with that, certainly, but it would be, they will absolutely, we kind of call them the quarterback of the healthcare system, right? Like who do you need to see next? Where do you need to go? Like what's the play? What are we going to do? And I've got a bunch of patients who actually come through the ER and they say, hey, will you check with my primary care doctor first? And, it'll be 12 o'clock at night. I assure you, your primary care doctor will be happy to hear about this in the morning. But that I think would be huge. And there probably needs to be little more effort on everybody's part, patients and providers, to establish these primary care relationships. Because I think that's probably where not the crushing chest pain or abdominal pain needs to be considered, but like, hey, this pain in my shoulder has kind of been going on for a while. Like, oh my goodness, like perfect scenario to skip urgent care and, the freestanding altogether. Like, start with your primary. But, that being said, I'm not going to be the ER doctor here that says shoulder pain should never be seen in the ER, because there's plenty of things that can go wrong. So that's, and after time in the trenches, you see all different things that have gone wrong. So it's like, hey man, if you're concerned, come see us. And, but having that relationship with your primary care doctor would be absolutely massive in helping get that figured out, and knowing that your primary care doctor can actually do a whole lot for you and get a lot figured out with you and for you. And
No, that's definitely true. I think a lot of people sometimes forget about that, right? But like, your primary care doctor is like supposed to be on your side, advocating for you, knows your history the best, right? So for a lot of these.
Well, and to that point too, it really helps us in the ER if someone did call their primary care doctor, or their primary care doctor sees them in clinic and calls us and says, hey, I've got Mr. Jones here. I'm worried about this thing because I've seen him for a long time, and there's something different today. I don't like what he's doing. And I mean, we've had calls like that end up, turns out they were having a heart attack. Hey, turns out they were having the big surgical emergency in their abdomen, and had something get surgically corrected that needed to. And so it's one of my favorite things, actually, when a primary care doctor calls about a patient ahead of time, says, hey, I'm worried about them. Like, this is what I've done. Like, this is what I know about them. If you can help me get this, figure this out, absolutely. Like, that makes our job that much easier and more effective. And so, I think the ER without primary care, because we are not primary care, right? Like, I don't focus on the same things. I don't have their training, and they don't have mine. So if you're walking, talking, breathing, and you're not having crushing chest pain, and you can have a moment to make a phone call or show up to your primary care office, a lot of them will have sick visits or walk-ins, and I would talk to them about that. And, there's some that end up pretty busy, and we get that, but that would be a big place to start as well.
Yeah. Now, when do you think somebody should, instead of, having a friend drive them to the ER, like, when should they just stop and call 911? Which is kind of like a big question, but like big things that you think people kind of don't think of, and you're like, why did you just walk into the ER?
So vision problems, okay? If all of a sudden one side is just black and you can't see anything, that'd be a great time.
Yeah.
If you are having trouble speaking, if you are having trouble understanding something or following commands, then that would be someone, who's with you, that type of thing. Crushing chest pain, or just bad chest pain in general, and everything is relative, right? Like, sometimes things don't always present the same way, but if you're in a bad spot, if your abdomen really is just killing you, you're like, my belly. Those are great times. Number one, the EKG that EMS typically will get in a chest pain or shortness of breath scenario, the interventions that they can do can sometimes save days in the hospital, or just be flat out like the initial treatment that you needed, right? And so that is super helpful. So I would say, chest pain, weakness, numbness, trouble speaking, shortness of breath, or trouble breathing, that's when you need the ambulance to get to you. Now, sometimes people in one of the places that I work, their house is literally like within viewing, like a sight line of the ER. And if you can get in your car and get to our front door faster than you can call an ambulance, okay, just come straight to us. But, that's a judgment call. But typically, if it's breathing, chest pain, or excruciating abdominal pain, or something's not working, like numbness, weakness, your vision, or speaking, those are times you need to get an ambulance involved, or a trauma scenario.
Yeah.
So you fell off or something, get in a car accident, something has, been disarticulated or fingers come off or something. Those are good times.
Yep. And then also, I think, sometimes people need to, you brought it up, but like how far you are from the hospital, right? So like the further you are away, if this is something serious, right, driving there versus having an ambulance where they can actually do some interventions. I mean, I actually made this mistake with my oldest son. He had what ended up being an anaphylactic episode. But at the time, he has eczema, so I thought it was like, allergies and worsening rash and stuff. But I was like, we need to go to the ER right away. And I was like, and we have to go to the kids' ER because they'll be able to treat him better. And so we load him up in the car, and as we're driving there, then he starts, having more of like the tongue swelling and all this stuff. And I was like, oh no, this is anaphylaxis. I should have called 911. And it's like, but by then we were halfway through the car. So it's like one of those things where it's like, I should know better, and I did not.
Yeah, no, it's always hard when it's your own. You kind of
all of my medical knowledge just went out the window, and I just was not thinking. But, I think it's important, and that's something you can also talk on is, EMS, they can actually do some intervention. So, I guess like, what are some of the ways that EMS can actually like speed up treatment for some people? And I think that's something for people to be aware of sometimes when they're deciding to call 911 versus just, driving to the ER. So
the three that are straight off the top of my head, and I think are fairly universal, are strokes and heart attacks. Depending on where EMS in your county this is, some people don't think in terms of county, but that's the way kind of EMS and a lot of this healthcare stuff is sorted out. Because if you live in a bigger city, your kind of radius of livelihood and travel and those things shrinks quite a bit. But in the setting of a heart attack, if they can clearly see a clear-cut heart attack, depending on their location in the county, they may go ahead and take you to the cardiac interventional center. If they don't, and there's a million different ways to kind of assess or diagnose a heart attack, but one that would require intervention, they can get you to the correct place sooner sometimes. Stroke as well. So if, typical signs of a stroke would be a sudden change in vision, speech ability. Oh no, am I having one? Speaking ability, or understanding ability, and weakness or numbness. If EMS recognizes some of those signs, and there's two options that they're like right at the 50-yard line for, they may say, hey, we're going to go to the stroke interventional center as opposed to the other, maybe smaller place or something of that sort. So, and then trauma, certainly. So, a bad car accident, a industrial workplace accident, something of that sort. If they can see the injury that is going to require those things, and it's 5 extra minutes to this trauma center, that 5 extra minutes in the long run is actually, sometimes hours extra, because you're at the place that they're going to be able to do something about it as well. So certainly thoughts or signs of a stroke or heart attack, EMS always, and bad trauma. So, paper cut,
great advice.
those can, you can be the judge of that. But if it's bad, I would absolutely call 911.
Yeah. Because again, I like your explanation of like, one, there's the different hospitals, right, that have different levels of care and have like different interventions that they can do. And then, also like they can do certain things, right? So they have some oxygen, right? They can help, they can give some medicine. So like there's a lot of other things that they can actually give en route, that I think.
They have epinephrine for anaphylactic events.
Yes, exactly,
they have pain medicine that you can get a jump start on your pain medicine therapy, and as is deemed appropriate by them as well, because they have protocols and they have judgment calls as well. But they're usually really, really good about administering what they can for patients, because they want to see everybody feel better too. So
yeah, I think that's great. What would you say if somebody's like, all right, well, I'm going to the ER, like what do they need to bring with them? I mean, obviously if it's a true emergency, don't stop and get all your stuff, but like
I would say what you got on, and an understanding, open mind, right? Because just like any other service that you might be thinking, and everybody has different levels of knowledge about themselves and their bodies and how they work and how they feel. Some people be like, yeah, I felt this all the time. And like, well, why'd you come today? I'm glad you did, because this is happening. It's like, you feel this always? I'm like, oh yeah, this is every day for me. I'm like, I wish you would have come 3 months ago, based on what you're telling me. No, not 3 months, because that's then by definition also not the emergency. But you don't need to bring anything with you. Have an idea. And okay, so actually, if you have that yellow DNR paper, bring that. Yeah. I tell people to keep that, and that's a very special scenario set of circumstances, typically for older or terminally ill patients who do not wish to have cardiopulmonary resuscitation, CPR. And if you have that yellow signed in Florida, it's a yellow signed piece of paper. I typically tell people to have that magneted into their refrigerator, because that's usually a fairly central location in the house, and EMS, if they do get called to the house, might see that and say, hey, like, is that for, Mr. Jones here? And say, oh yeah, he would not want to be intubated. He would not want chest compressions, those kind of things. And that is crucial information. Yeah. So definitely bring that if that applies to you. But other than that, just come on in and we'll get you figured out.
Yeah. How helpful is it for patients to know their medical history, allergies, medicines?
Pretty darn helpful. Yeah. We are lucky that there's plenty of allergies that are absolutely real. The ones that really, really matter are the anaphylaxis ones. But one thing I'll tell people, because, we'll ask like, hey, do you take any medications? Are you allergic to anything? And they'll say, I got a list of stuff. Like, all right, well, the premise of that I like to explain is, Dr. McCarthy's a very good doctor, but how well do you know Dr. McCarthy? She's a stranger to you and she's telling you to put these things in your body. I would know the doses and the names of them, right? And same thing, like, well, I've known Dr. Anderson for years. Like, okay, well, again, this is someone who is not you who's telling you to put this stuff in your body. Like, if for no other reason, then you're just aware of your person. Good information to know. And sometimes if someone's on a certain medication, then that takes some things off of our list that we have to worry about, or not that we have to worry about, but we can say like, well, that medication treats this thing, and so we don't have to worry as much about this thing. It's like, it's important to know what you're taking, because it helps me figure out what I need to figure out and how it might be affecting or interacting with what's going on and what has brought you here today.
Right, yeah, because like you said, it can change vital signs, and also it can interact with some of like the treatments that you might want to offer, right? So I think that's something else for people to understand. It's like, well, some of these medicines do interact, so it's helpful for us like to know what medications you're actually on, right? And it adds to like the whole clinical picture. So
well, and I would prefer that someone in most scenarios will try to mitigate some of their symptoms. Obviously, like there's some kind of things that are very severe, but I'll say, like, what have you done or taken for this? Or what have you tried to make this pain better? And they say, well, I haven't done or tried anything. I just came straight here. Yeah. Which, all right, fair. Like, you're having this thing that you're really worried about, but, we can also try some things sometimes. So. Yeah.
I do think something that's cool is like a lot of the phones now, they have like those emergency like SOS contacts and stuff, so that like if somebody was like picked up, it's like it can actually have like people can enter their medications in there and their allergies and like all of that, which I think is a really cool thing with technology now that it can help with that.
Yes, that has actually helped a lot. I mean, in cases that someone has come in completely just altered mental status, obtunded, unable to communicate, we've found receipts in pockets that are able to get us to the last person who saw or bought, like where they came from, the store. And we say, hey, was this person having these symptoms when you saw them? Like, oh no, like they were a little funny, but they didn't act, they weren't having this thing happening. So the phone or, emergency list and those things, those are actually very helpful a lot of times.
Yeah. So now I think a lot of people, once they show up to the ER, they don't quite understand the process. Like a lot of people don't understand the whole triage process. So, how exactly does that work?
So the triage provider, who's typically a nurse with a significant amount of experience, has the hardest job in the hospital. That is not an original thought. That was, I forget, it was from one of my training podcasts that I listened to ages ago. I think it was probably Ian Basic, the guy on there. Don't quote me on that, but said triage is the hardest job in the hospital because you've got to communicate to everybody else, behind in the ER, that this person needs immediate care or maybe care as soon as possible, or like they can wait as long as needed.
Yeah.
So which can be very frustrating for patients because obviously, I mean, these days it feels like more than ever, everyone's time is either accounted for or things are moving at light speed. So a minute or an hour in today's world, would be equivalent to a week, 30 years ago. So a lot of stuff happens and changes minute to minute. So just that in the emergency department, we are, as a team, not just the doctors, but the nurses, the techs, everyone involved is pretty used to recognizing emergencies. Now, do we get that right 1,000% of the time? No, sometimes, vital signs might be a little reassuring when they probably, don't need to be or those kind of things. But that's just part of the process, is that, if it's not that someone's saying that it's not serious that you're dealing with, but we have to deal with, 20 people showing up at once and if someone's going to stop breathing, well, that's the one that takes priority, because that's what we're there for, is we're to prevent the loss of life, if at all possible, and the loss of limb. And so we try to do that as effectively and efficiently as we can. And unfortunately, sometimes feelings or arrival times don't align with those levels of acuity.
Yeah, I think that's a good explanation, because I do think a lot of people will go there and they're like, this person just came in and I've been waiting here for an hour, right? And so it's like...
Or 4 hours.
Or 4 hours, right? And it's like, well, yes, but, based on triage, like, this person was going to possibly imminently die or have something seriously bad happen if they weren't seen right away. So unfortunately, you got bumped, not exactly bumped, but, in terms of triage, this person took precedence, right? And so I think that's something for people to be aware of as well,
Yeah. And it's a changing thing, because everything is always relative. So it's constantly fluctuating. And, and I tell people before, like, you never want to be the first one in line at the ER, if that makes sense. Because if you're the first one and the one that everyone's worried about, you're the closest to that bad thing happening.
Yeah.
So you want to get the care that you need, but I mean, you don't want to be the most interesting one in the ER at any given point.
Yeah. No, I actually tell my patients the same thing that I've been in the hospital, because they're like, oh, when am I going to see you again? And I'm like, actually, you don't want to be seeing me multiple times during the day, because that means you're really sick. That's not what you want.
Yeah.
So what would you say ER doctors are really trying to rule out first, when they're evaluating a patient?
So airway.
Yeah.
Like, are you breathing? Is there something that is going to compromise that anatomically or physiologically? So anatomy being, is your throat actively closing? Is there some mass or something pushing on that is going to stop oxygen from getting to your heart, right? And the way to think about that is, I can only hold my breath for, back before when I was doing some diving and stuff, it was probably close to 4 or 5 minutes, but not a lot of people can hold their breath for even 2 minutes, right? That's a very long time. So breathing is always the utmost emergency, if that makes sense. The next would be so getting air into your lungs. Then the next would be lungs themselves, right? Are your lungs working like they're supposed to, or are they filling up with fluid in the wrong way? That can be bleeding or not bleeding. And do we need to do something about that imminently? The other then is your heart getting that oxygen and putting that oxygen out to the rest of your body.
Yeah.
And if that is compromised, either a occluded artery or aorta, God forbid, or something going up into your brain like a stroke, those are the things that we are going to always give precedence to. So a shortness of breath, a breathing complaint. There's some people that have chronic breathing issues that are just saying, hey, it's getting a little worse. And there's, some that are having an anaphylactic reaction and things are closing up here, they're tightening up here, and that oxygen is not going to be exchanging itself very much longer unless we do something about it actively. Yeah. So those are some of the big things we're working for to sort through and look at really quickly, and then going beyond that, then we get a little bit more imaging, x-rays, EKGs, things to look at the heart and the lungs. And I guess that's another thing wanting people to understand is when you show up to the ER, you are, for better or worse, declaring an emergency for yourself, right? And it's my job to take that seriously. So some people get frustrated, like, it's not that serious. And I say, well, it's, I'm an ER doctor. Like, you came to the ER, and if I don't take this serious as a heart attack, some people would use that common euphemism, then I'm not doing my job appropriately, right? And so I think that's another thing that I'd like people to understand is like, they say, oh, you're just running up this thing to get tests done or like to run up a bill or something. It's not about that. Like we're there to make sure that you did not get blown off in the ER. We're there to make sure that we're not missing a heart attack or those kind of things. And sometimes we can pretty quickly come to that conclusion, or sometimes it's a little more convoluted and it takes a little bit more testing and things. So that's a big piece of it.
All right. So kind of getting into our next section, just kind of, I think, some general education, awareness for people to know. I think, we talked about stroke and a little bit of the signs, but what would you say are like major signs that people should think of like for a stroke and be like, oh, hey, I should go to the emergency room or I should call 911?
Sure. So the big things are in regards to stroke, how you should think about stroke. Stroke is a part of the brain that's not getting oxygen. So if there's something in your body that is not working like it's supposed to, which unfortunately can be your brain and cognition. So some people having a stroke don't recognize that they're having a stroke. So this almost takes a kind of a two-person effort here, or if you're sitting in the room talking to someone and something changes. But visual changes, facial drooping, numbness in an arm, a leg, those kind of things would suggest that now something is not working correctly. There's other kind of more nuanced presentations of strokes that we find and figure out, but I wouldn't expect someone with no training in that field to be able to find it, because it can be tricky even with us and but the big things would be kind of sudden light switch on truck accident style headache. That is a form of stroke, or can be signs of a stroke. And so any maximal onset headache, that would be something to come in for.
Yeah, in med school we always heard of it as like worst headache of your life. Like
and that's and kind of like we talked about before, everything is relative, right? Yeah. So this could be the worst headache of your life. The more accurate thing that we like to talk about is maximal and onset. So something like I was going about my day and boom, there was a break in reality of I was fine and now I am not fine. I am having a bad time. And it's up here in my head. That would always be a reason to come to the ER. Yeah. And there's a bunch of people that come to the ER for headaches. We're happy to help you figure out your headache. And that's one of the things, that's a big deal that we dive into. And some people are like, why are you asking me all these questions? Like, cause I got to figure out what's going on. So weakness, sudden onset of excruciating headache or pain, visual changes, speech issues, facial droop, There's different mnemonics and things, but I like to say if something is not working like it's supposed to, something is weak, something is numb, and it's a relatively sudden onset, within 3 hours, 4 hours, because those are our treatment windows that we can do something about these things. So, we get a bunch of people sometimes still that, this started like 2 days ago and I thought it was going to get better. It's like, well, good thing is it hasn't gotten worse from what this is, but now we have to figure out what it is that we can do about this. And so
yeah, and I think that's important for people to know, like that there is that window where for some of these there is intervention that can be done. It can make a huge difference, right? So it's like recognizing those symptoms and going to the ER. And also like for friends and family, like you said, a lot of times people don't quite realize, right? And so it'll be like the family member or friend who's like, hey, you need to actually go get this checked out. We need to call 911. We need to do something. So like, I think it's important for like people to be aware. I think another big one would be heart attack. What are like the classic signs, and are they always obvious?
So unfortunately, not always obvious. Yeah. The classic thing would be the crushing left-sided chest pain radiating to the jaw and arm. Yeah. With some sweating, and some of these we call typical chest pain. Like that is the typical sign of a heart attack. Now, not everybody will experience those things. Some people, heart attack also is kind of a big pot of different conditions and things, because you can have, some people might call a type 2 instemia heart attack because their troponin was elevated, which is, a lot of technical speak for, a form of what could be considered a heart attack. But when we talk about heart attacks, classically, we're talking about an occluded vessel that is supplying the heart muscle itself. Yeah. So those are typically not symptomatic. Different populations, older women may not experience classic signs of a heart attack. They might have maybe just a little bit of indigestion. I just wasn't feeling right. And I mean, you'd be hard pressed to tell someone who's, usually pretty, taking care of themselves, used to taking care of themselves, like, hey, you should go check it out. Like, it's nothing. And I mean, you hate to say, only come for the excruciating stuff, but if you feel like something is not right or not usual, like, that would be seek medical care in some aspect. And the cool thing about medicine in America, as far as the systems issue, is we do have the right to choose when and who we see, for the most part. And some people say, I didn't want to go to a doctor. And I would prefer to have that freedom than the alternative, right? Like, well, you didn't go to a doctor in this time frame, now you're punished. Like, well, no, you chose not to, and that's okay as well. As long as, that's just life on a rock flying through space.
Yeah. But I mean, I think it's important, like the classic symptoms people think of, right? Like the crushing chest pain, the going up to the jaw, the down the arm, the sweating, feeling nauseous. But then there are that
straight to the back.
Straight to the back. Yeah, that's another big one, important. Yep. But then there's also like that population, right? If you're diabetic, then a lot of times you're not, the way your nerves work and pain processes can be different, so sometimes they're not going to feel it the same way. Women, like you said. So there is this population where it's always, I think, a little bit different, and that's something for people to be aware of. We live in Florida, so I had to ask about heat stroke. I mean, I feel like we see this all the time. I do, at least, in the hospital. I don't know how much you see it. But what do you think people should know about heat stroke?
So heat stroke and brain stroke are different processes. They are not on a continuum. They're just, someone was like, it's a heat stroke. It's like, okay, well, what is heat stroke? It is the discoupling or dysregulation of your metabolic processes due to an excessive environmental exposure. So presumably external heat. I was outside. I sweated too much. I now have electrolyte imbalance, and my body temperature is consequently elevated because my body is now, number one, not able to get rid of the heat that I need to get rid of, or something has gone awry and internally is causing this kind of hyperthermia. So the big signs to be aware of in those kind of exposure related illnesses is what I'd prefer to I guess call it, would be, nausea, vomiting, sweating profusely, and then zero sweating. So like bone dry skin, like, wow, it's really hot outside. I feel really hot. I should be sweating. That's a problem. If you just now all of a sudden are not sweating. If you're having some confusion or trouble processing, or you're talking to your friend who now all of a sudden seems not right, it's like, hey, John, like, what's going on? And John's now like over there stumbling and mumbling, and usually he's a pretty sharp dude, and those would be signs of heat related injury or illness, or excessive urinating or not urinating enough. Those would be issues, and that takes some time in these environments, right? It's not going to be like, oh, it's 110 degrees outside, I was outside for 10 minutes, now I'm having a heat stroke because I don't feel good. It's like, well, it's hot outside, like it's not comfortable maybe, but those kind of, hey, something's not right. And sometimes those illness spectrums can be turned around with a bag of fluids and say, hey, how you feeling? How you doing? We can get you home. Sometimes it's not just a bag of fluids. Sometimes it's a lot more than that. And so those are things that we're happy to get checked out as well.
Yeah, I feel like it happens fairly commonly here. Like TPC, they actually, because that happens here, they moved the time back, which I was really happy, because last year the amount of like patients who came in, because I felt so bad, like, they were just out in the heat, you're out all day, right? And there's not much like coverage and stuff. And so I was happy that this year they kind of changed the date based on that, because in Florida, people forget it gets real hot. And if you're out on the golf course all day in the middle of summer, it's rough.
Well, and you're insensible losses, right? So you are sweating and your respiratory rate goes up, and people don't give credit to how much fluid you actually lose and gain by breathing. Spend a few hours on a plane going anywhere, and you'd be like, oh, like if they don't humidify this air, like we're all like, asking for ice water or something, because you do lose a lot through that. So stay hydrated, and stay protected in the elements from wherever you're living.
Now, I'm sure you see this a lot too. How, I guess also when should people come in for like food poisoning, or like, when should they be worried about something more serious? I think a lot of people can stay home, and then there's like the other category where, hey, you actually need to be seen, and you're getting really sick.
Yeah, no, that's a tough call to say. I mean, it's tough to give maybe general advice in that regard. Some of the questions I'll ask is to kind of help figure this out sometimes then would be, has anybody else had similar symptoms after eating the same food as you? Like, oh yeah, like, well, we ate at this, buffet and we were all pooping after that. Or, I vomited, and, my wife vomited, my kid vomited. It's like, all right, well, that's, probably, food related in that case. Or we're on a road trip and everybody had their hands in the bag of chips and something of that sort, right? So, and then the duration of symptoms. I mean, you don't want to delay someone getting care, but a lot of those kind of viral illnesses, stomach bugs and those things, will pass in 24 or 48 hours. Sometimes they don't. But usually, if you're not having, the crushing chest pain and excruciating abdominal pain and those kind of things, it's just uncomfortable. Diarrhea is uncomfortable. And so if it's just discomfort, then, it's more likely one of those other things. But there are serious bacterial illnesses that can occur. There's, bowel obstructions, all kind of number of things, constipation. So, that's kind of hard, in my opinion, to apply a one-size-fits-all thing to maybe those stomach bugs, because depending on your surgical history, that could maybe be something more ominous, depending on your age or, exposures or other medical history. So, that's a tough one to call, but
it's like
24 to 48 hours. Yeah.
Yeah, like all medicine, very nuanced. But Yeah, I think I always tell people, like, if you're able to like keep enough fluid down, like, and you're, everybody knows their body the best, right? So I also think like that's where sometimes people need to use some common sense of, hey, is this like debilitating and you're not able to eat and drink and you feel really, really bad, versus like, hey, diarrhea is pretty miserable, stomach bug is miserable, but you're like still functioning and fine and you're a relatively healthy person, right? So there's like the differences there too. But yeah, stomach bugs are the worst. They like just messaged me actually that there's a stomach bug going around in my son's daycare, so I'm looking forward to that.
Woohoo!
The gift that keeps on giving, daycare joy.
Yeah, absolutely.
So concussions, I think that's another big one. When, like, what would you say a concussion looks like, and when should somebody get checked out?
Again, kind of another tough one, because a concussion is a head injury without radiologic signs of head injury. Okay, yeah. So it's one of these things where there is good description of what we can see. And that is another age and symptom dependent, as well as medication dependent thing. If you are a young kid playing sports and get bonked in the head and go, whoa, and you're seeing stars for a second, that would, there's grades of concussions, but that would count typically as a concussion. But someone who probably needs to be checked out imminently in the emergency department is someone who has lost consciousness completely and then regains consciousness, or if they don't regain consciousness, for sure need to be in the ER. Someone who is vomiting very soon after this event, or after a little bit of delay and they're just repetitively vomiting. That's typically a big issue. Or someone who has numbness, weakness, or kind of those signs of a stroke that we already talked about, vision changes. And, it might take a few hours in the ER to get some of that information back, but that's the check, and we're happy to do the check. But the vomiting, change of vision, ability to speak, numbness, weakness, or signs of a visual head injury, like evidence of something that's way out here, or depressed, anything of that sort, always straight to the ER.
Yep. And like you said, medications are important, because I think so many people are on baby aspirin or blood thinner, and it's always what I tell people: if you're on anything like that, automatically go to the ER. Because someone who's got AFib and is on Eliquis, or warfarin or Pradaxa, or any of those other like anticoagulant medicines, which are incredible medicines that have done a lot of really good things for people, also have the opposite edge of that, to like, if that turns a potential trauma into a bigger deal. And so I tell everybody, if you bonk your head and you're taking one of those make you bleed medicines or blood thinner medicines, just come to the ER. If we do nothing else other than get a head CT to say, hey, there's no blood there, then like that's it. And it's the risk that you undertake. You don't want to miss it. Yeah, because again, the medicine's doing its job, right? It's thinning their blood, which means bleeding is then easier if you have something like that. So it's better to get it checked out. Allergies. So we talked a little bit about this, with my mistake with my son. But what do you think people should know about allergic reactions and when they become an emergency?
So allergic reactions, when they're emergency, the things that we are looking for are signs of hemodynamic instability. So low blood pressure, high heart rate, pulses that are maybe weak and thready, not really doing what they're supposed to, shortness of breath, something that feels like it's grabbing you up here and changing the way that your voice sounds or how easy it is to talk, or profound abdominal pain, or sudden onset nausea, vomiting, diarrhea that you really weren't, expecting. And allergies, you can be allergic to anything. Unfortunately, it is your immune system's processing of a protein that is encountered. So, you can be allergic to another person, you can be allergic to a medication, you can be allergic to bees. Having one allergy does not make you more likely to be allergic necessarily to everything else. But, if you have a strong family history of allergies, then, genetics being what they are, you may. But everybody's immune system is different, so you're not guaranteed to have them. So what we're looking for is trouble breathing, sudden onset, cramping, vomiting, diarrhea, shock, or signs of shock, low blood pressure, high heart rate, for what we'll typically treat with a version of epinephrine. And if you have an EpiPen, some people have EpiPens and allergies, and they're well familiar with that, and say, hey, if you use your EpiPen, come get checked out. And because there's about a 20-minute lifespan, or half-life, we call it, that epinephrine's efficacy. So maybe it completely reverses everything and you only need the one dose, but it sometimes is a little persistent, especially if you ate something and didn't puke that thing up, or something's under the skin that needs to come out, that kind of thing. So
yeah, which I do think that's important to know. And that's why, like, with the kids, like, they actually have like the 2 EpiPens, is because you can get that where you need a second dose because of that. So very important, if somebody has that, then to go to the ER. If you use your EpiPen, then go to the ER.
Yeah.
What would you say, we talked a little bit about stitches. I think that's a common reason to come to the ER. What do you think people should know in terms of, like, if they cut themselves, like, when should they go to the ER? What should they know about that?
So all cuts are different. Sometimes there's a little kind of paper cut. I've actually put a number of Band-Aids on where I say, hey, look, this really doesn't even need stitches. We'll put some Band-Aid on it. And some people are very relieved at that, and some people are kind of upset by that, but that is what it is. Certainly, if anything is squirting, like if blood is doing that deal, absolutely come to us. Before you get to us, depending on the severity, your comfortability, and where this thing is, right? If it's on your fingertip and you can put one finger on it to stop the bleeding, put one finger on it. If you can stop the bleeding with 2 fingers, put 2 fingers on it. Things that are not as helpful are, someone grabs a glob of towels and just like puts all this stuff on it. That maybe keeps the blood away from the person who's helping, and maybe that's what it takes to get them here. But a general rule for treating something that's bleeding is, if you need the bleeding to stop, use the smallest square footage or square inches that you can. So if it takes one fingertip. If it takes 2, it's 2. If it takes 3, it's 3.
Yeah.
And if it takes your whole hand, put your whole hand on it. But a lot of times, 1 or 2 fingers will do the trick. And then for cuts and things, alcohol and peroxide are good for intact skin or maybe very minor abrasions, but they are not the best for open, broken skin. So if it's a smaller cut, but you think, hey, I think that's going to need stitches, if you have clean water nearby, like a running tap water, you can flush it, wash it with that. That can be helpful, depending on, again, the size and severity. If you're like, whoa, dude, my finger's almost coming off, like, come to us and we'll do it at that point. But if it's a smaller cut that nothing's hanging off, it's just broken skin, avoiding the peroxide may be a better move than dousing it in peroxide, because that can be cytotoxic, slow healing, worsen scarring, those kind of things. But at the end of the day,
what about like burns? What should people know about that? Like if they like burn themselves in the kitchen or something, like a common sort of. Cool
water for as long as you can before you come to us. So not ice water, but just cool water in a sink for as absolutely long as you can. If it's like a water splash burn, those kind of things. Oil burns are maybe a little bit different, because depending on the contact and that, do not put baby oil or any other oil-based thing on it acutely, because that can intensify some burns, especially if it's a thermal burn. But there's various types of burns. There's chemical burns, acid-based burns, but almost universally, large amounts of cold running water over a burn are good things. That's the first and the last thing that you need to do. And, we can get you taken care of and figured out. If you need to go to a burn center, or, I don't work at a burn center, but I've sent plenty of people, and I'll send plenty more. And, or I'll sometimes just talk to the surgeon about a follow-up visit. So. Yeah.
And then fevers, I feel like, people get sick, they get fevers. When should they be really worried about a fever?
Ooh, that's a huge one. Because that's one of our, 4 vital signs that we have, right? Like, what is your temperature? Fever is a response from the body to deal with a stress or illness or some chemical signaling. So that can be from, heat stroke, like we said, or a heat-related exertional thing. If you measure your body temperature after a marathon, oftentimes you'll have elevated temperature. But when the fever is associated with something else, so from the pediatric side of things, a fever in isolation, truly isolation, is your body responding to something. And if it's just responding to something that, it's dealing with, and you feel okay, not having trouble eating, drinking, peeing, pooping, then great. Yeah. That's good. Now, if you have a fever in conjunction with excruciating abdominal pain or profound shortness of breath or, a yucky wound or something on your arm or hand or foot, those can be big issues. And so that comes down again to knowing yourself, knowing, if you do have a primary care doctor and you say, hey, I'm not feeling great, like, I've got this thing, they can sometimes sort that out with a phone call. Sometimes it'll be, they will recommend, hey, just head into the ER and get you checked out, and give me a call if something changes or gets worse. But and then sometimes, we'll see it and say, hey, I don't really see anything right now on your labs or imaging, or if we got labs or imaging, or say, hey, this is, the first few hours of this thing that you're experiencing. Maybe come back in 24, 36 hours, see what has progressed, if there's more symptoms or something for us to kind of chase or evaluate. Because right now, kind of hard to say where this exactly might be coming from. So fevers are kind of a tough one because they can be very simple and, just be related to, some kind of rhinovirus, but rhinovirus infection is not the exact same in every single person, because some people are immunocompromised. Some people, don't produce a fever or those kind of things. Traditionally.
I always think of our jobs, even though they're very different, right? You're in the emergency side and the hospital side, but we're like detectives. So it's like, okay, so you got this fever, and then what's all of the other part that's going with it, right? Like, are you walkie-talkie? Okay, is it like COVID and flu season? Are you having all the other COVID and flu signs? Or, hey, do you have this high fever and your leg looks horrible, and that could be a really bad infection? Or do you have this new really bad abdominal pain and, all this other stuff that's going along with it? So I think, again, like you said, when you have a good primary care, that's where it can kind of help, because then they know your history, they know all this,
Yeah.
There's so much that goes into it. So
it's huge.
Yeah, it is. I think
that's the takeaway from the takeaway from the ER conversation is get a primary care doctor.
Yeah.
Because they are so good at what they do, and they can be such assets to your life and healthcare.
Yeah, absolutely. So prevention, I think this is, part of what I love the most about, medicine is, hey, let's see what we can prevent. So you see tons of crazy stuff all the time. What would you say are some of the top emergencies that you wish people knew how to prevent?
Oh man. Probably some of the basic plain Jane boring stuff. Helmets, and that's a huge thing if you're riding a bike, especially these e-bikes these days.
I know. I feel like every time I turn around, there's another e-bike crew that's just nice helmets, and they're flying. Man. They're going faster than a motorcycle.
Yeah, and it's so wear a helmet, because your brain, you got one of them, and they don't heal super great if something does happen to them. It's helmets are crucial. Seatbelts, I mean, like the simple stuff. And I used to not, growing up, like seatbelts because, man, they're not cool or fun or whatever. But like, man, it makes a difference when we see someone in the ER and they had their seatbelt on.
Yeah.
It's like, did you have your seatbelt? They said yes. Like, I'm really glad you did, because the other person in the vehicle did not have their seatbelt on, and they're in a very different situation right now.
Yep.
So helmet, seatbelts, like simple things. I'm a proponent of living life and being adventurous. So don't, shy away from a challenge or an adventure or some kind of physical thing, but like just do it within safety, with that in mind, if that makes sense. Helmets and seatbelts, that's a pretty simple thing.
I know, it really is. And I feel like now, seriously, there's always all these like e-bike, I call them e-bike gangs, but it'll be like a bunch of kids riding around and they're flying and there's no helmet. And I'm like, oh my gosh, So
one of the issues with those too is they're silent. So we are biological creatures with senses to tell us what is happening and where, and those e-bikes make next to no noise. So if it was a motorcycle, you can hear it coming. And unfortunately, that's for better and worse, the e-bikes are silent. You don't give any warning to anybody other than a wah, if something's happening, and because they can't hear you coming, they might pull out or something. That's a whole different can of worms. But
no, I know. But it's also on like the same line of like, since it's a bike, like a lot of them will be like on the sidewalk, but then on the road, and then back on the sidewalk and then on the road. So like you're also, people aren't looking for them, in all the areas where they'll be riding them. So what would you say is like one of the biggest safety mistakes that you would see at like the gym or at home, people playing with their kids? Are there any that like stand out to you?
It seems that we have a lot of, bedtime head lacerations in toddlers.
Really? I actually believe it though, because it is like wrestling an alligator. It is wild.
Yes. Yeah. Jumping onto bed, running through the house, like just got out of the bath, got like a free spirit and bonk. And it's always just like a little thing.
Because they're like wet, and so like you're like trying to grab them. It's literally wrestling an alligator.
It's, if I put my money on the table or cards on the table, whatever you want to call it, I'm not a gambler. It's pretty inevitable that 8, 9, 10 p.m. little ones getting ready for bed, jumped off of something, we're running through the house and blonk and have just a little forehead laceration. So I don't know, other than what you would normally do to prevent that. I don't know. Just keep your toddler in a small, soft cage in a little bubble. Nothing bad will ever happen to him. But
I have learned my lesson of keeping the bathroom door closed, though, when I get them out of the tub, so that there can't be like a sprint after, like
just down the hallway to the right. So that's just something that happens. But it is kind of funny that it's like 10 o'clock and it's like, little Johnny was running a little quick.
Yep. Anything crazy at the gym that you can think of? I feel like I always see those videos of people being idiots at the gym, but there's like nothing that really like stands out to me, right? Like, probably if you're using weights, like make sure the clip is on, just common sense things. But
I think there's, depending on the gym, there's certainly a lot of increased safety equipment and things that are safer these days because they're not relying on just like a free weight or free bar. I think that's where a lot of some of the weird stuff comes from.
Yeah.
But, training within reason, with goals, not just trying to, get in there and be a Hercules and just, I'm going to go all the way to the top and, doing what you can, sticking within, growing, but I don't know, have a spotter, like use the stuff that is not either on a track or one kind of rail system, with caution and just, within know your limits, I guess, or find your limits, with caution. Yeah,
that makes sense. What would you say, like, for a household to have for emergency supplies? What should be in, like, their emergency kit? kind of like a first aid kit, I guess. I'm the worst with this. Like I had to like search all over for Band-Aids the other day. So I need this advice.
Band-Aids are very helpful. You could keep some sort of antipyretic, which is a fever reducer. Yeah. So Tylenol or Motrin. Those are more comfort things, but it's okay to use those within reason. And Band-Aids and some form of antihistamine can sometimes be helpful. Yeah. There's a number of medications, commonly Benadryl or diphenhydramine, can be good for kind of minor irritations or hives or something of that sort. But if you're reaching for those things, kind of also have a suspicion like, I wonder if something else is going to go on or get worse. And if you're reaching for all these medications either routinely or a period of time, that may be a time to get a hold of some kind of medical professional, primary care doctor. If you're reaching for the over-the-counter stuff at home, then that would be good to call them about.
Yeah, I know. I need to get all my Band-Aids. It's like we literally just have one size that I found now, and I'm like, this is like the worst.
It is cool. They have the whole multi-size whatever, and you don't need them until you need them.
Yeah, I know. That's the issue. What is there any like basic first aid knowledge that you think everybody should know?
I think the fingers, if one finger stops the bleeding, if two fingers stops the bleeding, that's probably the most effective because, and then don't check it for 10 minutes. I think that was the other piece I missed. If it is a small little cut that you can put a finger over that stops the bleeding, don't check it because you keep looking at it, stretching it out, trying to look at the bottom, you're just going to disrupt the clot or those things. But, that's probably the big safe one that I'd let everyone know about.
Yeah, that makes sense. Well, I think this was great. Is there any, I guess, just to kind of close with, is there like one thing that you wish every patient knew before walking into the ER?
Ooh, one thing. Can't speak for everyone and every provider or every ER experience because there's been as many people on the planet, as many opinions of an ER. And the ER is not going to be the most comfortable place, but it is typically full of people who are trying to get you help and get you figured out and to get your situation handled. So it is one of the things that makes us, tick and makes us happy to help someone feel better and get that thing that was an emergency handled or taken care of. And that, that's that the people are there to help you get feeling better.
Yeah.
And identify and treat emergencies.
Yeah.
And that is always going to be our goal and our wish.
It is. And I also think like you guys have the hardest job because we talked about it a little bit, but it's like there's that whole triage aspect of like trying to figure out which patients, could like die on you right away versus like hopefully won't, right? And also like treating everybody and like figuring out things just like, somebody that you don't know that you've never seen before, that you're just now, here is a situation and, how on the scale of emergent is it, So I think that's like something important for everybody to remember too. So, well, this was awesome. Thanks so much for coming on the show. It was so much fun, and I'm sure we'll do another episode soon. But as always, this is not intended as medical advice. This is for educational purposes only.
Absolutely. And and if you're having a problem, head to the ER. We can get it figured out.
Exactly. Yep. You guys are there. So.
Yep.
All right. Well, thanks. It was good seeing you. Have a good one.
Thank you for joining us for the Duration Wellness Show. We hope you feel equipped to apply today's science-backed insights to your daily life. To find show notes, past episodes, and all the resources we mentioned, visit us at durationwellness.com. As always, this podcast is for informational and educational purposes only and does not constitute medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The views and opinions expressed by guests are their own and do not necessarily reflect those of the host. We'll see you next time, and as always, we're here with you for the duration.